Well, welcome everyone to our Monday lunch live stream, and it is great to be here. I think Victoria is really starting to come back to life, and it's really special that we can all be here together today. My name's Kirsten Pilati. I am the CEO of Breast Cancer Network Australia, and I'm actually thrilled to be emceeing today because it's such an important area of supportive care that BCNA has been advocating for a long time. I would like to begin by paying my respects to the traditional owners of the land on which all of us meet today. For me here, it's the Wurundjeri people from the Kulin Nation, and I pay my respects to their elders past, present and emerging. And I think it's really important for us to pay tribute to our First Peoples because we must provide a healthcare system that tailors all of our supportive needs to the different cultures and people of this great country. So I'm just going to start with a couple of housekeeping. We do have a number of VCCC online events coming up, and I'm thrilled that a BCNA past board member, Christabel Saunders, is the next person getting the best value for our cancer patients. So I would encourage you to stay on top of all of these events. Make sure you register for any that are relevant to you. So with today, if you do have any questions, there are two ways to do them. You can either add your questions to the Q&A section or use the chat section underneath. And I think we're all getting pretty au fait with how to deliver those, and we will get to as many questions that we can. So let's kick off into introducing our main speaker, and it is fantastic to have Associate Professor Lesley Stafford here. Lesley has done a lot of work with Breast Cancer Network Australia, and Lesley, I want to, before you start, just really thank you for your involvement of consumers in your projects. It is wonderful that you've been able to access over the years our very amazing, and hello to all of them that might be online, consumer representatives who are trained through our Seat at the Table program for Breast Cancer Network Australia. So Lesley, I know that you are driven by the consumer needs. So I'll do a quick intro while Lesley pulls her slides up. So Associate Professor Lesley Stafford is a clinical psychologist who works predominantly with women diagnosed with breast cancer and women considered at high risk of developing breast or ovarian cancer. She is a principal fellow in the Melbourne School of Psychological Science at the University of Melbourne. And Lesley's research interests focus on understanding and intervening in psychological factors contributing to the burden of disease associated with breast cancer and gynecological cancers. She has a strong interest in translating research into practical implementation and practice. So Lesley, I'm going to hand over to you, and just a reminder to for people to put the questions and answers in the box below. Thanks, Lesley. And the slides are all good.
Thank you. Thank you very much, Kirsten, for that very warm welcome, and good afternoon, and thank you to the VCCC for this opportunity to join you and discuss this very important topic of mental health in breast cancer. I plan to cover quite a bit of material in this talk, and I'd like you to come away from this talk with a better understanding of how common psychological distress is in breast cancer, how this distress can manifest, and when to seek help, where to seek help indeed. And I'll also be leaving you with some ideas for promoting mental health in the context of cancer. If there's sort of one take-home message from my presentation, I'd like that to be that maintaining and promoting mental health in the context of breast cancer, or any cancer indeed, should not be considered a luxury or an add-on. Instead, it is an integral component of your treatment and quality of life. So this is true, as I said, for any type of cancer. So the majority, in fact, of my talk today is relevant to and applicable to all types of cancer, not just to breast cancer. So if you're a consumer tuned in today, and you have been diagnosed with breast cancer and are struggling with your mental health, please know that you are not alone. about 4 in 10 women will have significant distress of some description. And that distress can present in a range of ways. There can be symptoms of depression, anxiety, fear of recurrence or progression, sleep problems, sexual dysfunction, and this is by no means an exhaustive list. And often these symptoms are worse shortly after diagnosis and during intensive treatment, but we also know that many of these symptoms can persist for years after diagnosis and completion of treatment and go well into survivorship. So there is that sort of myth that once treatment is over, the patient should be better, that it's all in the past, but in fact, the evidence shows that some of those problems persist and in fact can begin only at the start of survivorship. At the same time, I want to emphasize that whether you're a person with breast cancer or a health professional, that by my saying it's not uncommon to experience these symptoms, that's not the same as saying that they don't need to be addressed. They most certainly do. So we know, of course, that breast cancer and all cancer diagnosis and treatment doesn't happen in a vacuum. It happens amidst busy lives. It happens to women who are mothers, partners, carers, workers with all sorts of responsibilities that don't simply cease just because you're sick. And so the disruption to everyday life can be very substantial. Generally speaking, in my own clinical practice, I see this disruption manifesting in one of 2 ways. There are 2 general themes. The one theme reflects loss and a sense of grief, and the other theme centers around fear and worry. So if you have a look at my 2 diagrams, you'll see, looking at the diagram on loss, that women can experience multiple different losses and to varying degrees. There are very tangible losses like losing your job, losing your hair, losing a breast. And then there are the more intangible losses, like a loss of identity, a loss of certainty, a loss of femininity, or a loss of hope. Certainly, there is a theme of loss of opportunity that accompanies cancer. And sometimes it's these themes of loss that feed into depression. So the other theme that runs alongside themes of loss is fear and worry. And some of these worries are based on events that are currently happening, but usually the worries are future focused and take a what if form. So thoughts about what if my cancer comes back, or what if my cancer progresses, what if I can't stand the pain of the surgery, what if I suffer. And often a major worry, particularly in the breast cancer population, is about the impact of caregiving and the well-being of dependents, especially younger children. This is actually it's a special interest of mine, and I thought I would take this opportunity to let you know that for the vast majority of children who have a parent with cancer, they actually do okay in the long run, and most do not experience long-term psychological consequences of their parents' cancer. So it may seem like I've painted a fairly gloomy picture, but the truth is it's not all gloom and doom. Distress is common, yes, but my experience and quite a bit of research data actually shows that women can benefit or grow psychologically and spiritually as well from their experience of cancer. And women report these gains in a number of domains. So there's a greater appreciation for life, and this is often expressed as having more regard for life's value. There's a greater openness to new life experiences, and often women will talk about changing their priorities or making different life choices in the context of their disease. Another domain is improved relationships with others, and there can be enhanced feelings of closeness or intimacy with friends and family. Another domain is spiritual development. So it's not uncommon for a diagnosis of cancer to bring about an interest or a renewed interest in religion or the addition of spiritual depth to one's life. And finally, there's a sense of personal strength that's spoken about, a sense of increased mental strength and empowerment that can accompany a diagnosis. One of the questions I'm very often asked by the women in my clinic and also by health professionals is how much anxiety is too much? What's normal and what's not normal? So I think this slide will go some way towards answering that question. Normal anxiety, I guess, is feeling stressed or worried under pressure. And certainly there's plenty of that to go around when you have a diagnosis of cancer. But when it's normal anxiety, I guess that feeling passes. And when it's so-called normal anxiety, the thoughts or feelings or behaviours don't have a significant impact on your day-to-day life. They don't control you. But when anxiety is too much, and you should consider seeking mental health support, or if you're a health professional, referring your patient to someone for additional support. This happens when the worry is difficult to control and is quite intrusive. So it intrudes on your daily experience. You should seek help if you're having episodes of intense fear in the form, for example, of a panic attack. If you find that you're having ongoing upsetting dreams or flashbacks to traumatic events, also a good idea to seek help. If you're having difficulty making decisions or finding social situations difficult to manage, or using alcohol and drugs to manage your feeling, again, that's time to seek help. So that's anxiety. Similarly, what is normal sadness and how much is too much? When should you seek help? So again, it's very normal for us as humans to have ups and downs, to feel irritable or sad or frustrated or angry, as long as those thoughts or the feelings and behaviours don't have a significant impact on day-to-day life. Very important though to seek support, formal mental health support, when you find that you feel sad or down most of the time for more than a couple of weeks, and where those feelings of sadness are intense. Another key issue to watch out for is losing interest or not being able to take pleasure in your usual activities. Now, I recognise that there may not be as many of your usual activities to participate in if you are unwell, and I think everybody had a taste of this in COVID, that the range of activities is diminished. But the key thing here is whether you still have the capacity to experience pleasure and have fun if given the opportunity. Other key signs for you to watch for in terms of seeking support are socially withdrawing from your close friends and family, feeling constantly overwhelmed and not able to make decisions, using substances, drugs, alcohol to escape or to manage your feelings, and feelings of worthlessness or helplessness or inappropriate guilt and hopelessness. Certainly if you have thoughts about yourself like you're a failure or life is not worth living, it's really important to reach out for help. And of course, any thoughts of harming yourself are a sign to you that you do need to seek help in the not too distant future. So I guess, why does that all matter? What's the big deal about mental health? And the big deal is that depression has very serious implications if it's left untreated. It's been associated with higher rates of mortality. People with depression are also far more likely to not adhere to their prescribed cancer treatment. They tend to stay in hospital for longer when they're inpatients and tend to experience physical symptoms and treatment side effects more severely. So there's a substantial impact on quality of life, which is a very real issue. But I guess perhaps to me as a psychologist, the key issue is that depression really interferes with our ability to make meaning out of our experience. And without meaning in the context of a cancer diagnosis, which is often associated with suffering, it's really difficult to have hope. And as we know, hope is really important to keep going. This slide I've included because it separates some of the myths from the facts about mental illness. So I will often hear that depression is a sign of weakness and that antidepressant medications are addictive or change personality, and patients will say they're not prepared to consider the diagnosis or the treatment. But the truth is that depression is an illness, and like other illnesses, it may require medication to manage, and medication requires medical supervision, and it is as simple as that. It is not addictive and should not be changing your personality. It's also common for me to hear that seeking help is a sign of weakness, or if this is not stated, it's sometimes implied. And I would say that it is in fact quite the opposite. I see seeking help as a sign of strength, as a sign of healthy adaptation to an abnormal stressor. Sometimes those experiencing depression and anxiety, particularly in the more severe forms, can feel really hopeless and despairing and can believe that nobody can help or that nothing can be done. And this is untrue. So in fact, depression and anxiety treatments are very effective and available from a range of sources. And I'll talk about that in the next couple of slides. So finally, as I said, many think that taking care of your mental health, particularly when you're faced with a potentially life-threatening condition, is a luxury and that your physical health is the absolute priority. But as I said before, mental health is not a luxury. It's not an optional bonus. It's absolutely integral to recovery and to good quality of life. So this slide depicts the levels of support that one might need in the context of a cancer diagnosis. So depending on the type of care that you need, there are different kinds of support available. So the majority of people are quite fine to self-manage and talk to friends or family or read some of the information provided by the primary care team. So that's most people at the bottom, at the fat end of the pyramid. And these people would benefit from information and practical support about treatment and side effects and so on. And certainly places like the Cancer Council website and their telephone helpline, and for women with breast cancer Network of Australia are very useful for this. There are lots of resources on those sites. And you can also receive this support from your primary team. If you have mild or moderate distress, you might start thinking about joining a group program or peer support from a forum like BCNA. Sometimes group programs are offered at hospitals, sometimes they're offered through the local Cancer Council. And then again, there are also peer support groups that arise informally through social media, particularly through Facebook groups. I would just, I guess, like to caution the consumers in relation to support through a group like Facebook. These groups can often be quite wonderful and tremendously helpful, but if they're not moderated or facilitated by a professional, they're not for everyone, and they can also be harmful and contain inaccurate or harmful information. So generally one is far better off attending a peer group that's facilitated or moderated through an organisation like the Cancer Council or BCNA. But that's not to take away from the real sense of connection that one can experience by joining one of these groups. Now, as you go higher up the triangle towards the more pointy end and distress gets worse, the need for specialised care increases. And here we start thinking about nurse counsellors or social workers, psychologists, and ultimately right at the top where there is very severe distress, we think about psychiatrists prescribing medication. So as I said, well, just about everybody can do with someone to talk to. Not many hospitals have specialised mental health clinicians available to their patients with cancer. Unfortunately, those are not warranted for most patients. So please remember the very important role of your GP in facilitating care, and I'll talk a bit more about this. So if you do need support from a professional, there is your hospital treatment team as a starting point, which at the bare minimum would have an oncologist and a nurse. And this is an excellent starting point for referrals if these are needed and available to a specialist service. And some hospitals, like in the VCCC, are very well resourced relative to some of the more regional or rural settings. In the community, your GP is your first point of clinical contact, and the GP can assess your concerns, discuss treatments, and make appropriate referrals to mental health clinicians. Some GPs are actually trained to provide brief counselling therapy, brief psychological therapies, and GPs are also trained and quite able to prescribe and supervise psychotropic medication like antidepressants. Now, your GP can refer you to see a psychologist or a clinical psychologist in the community. And there are a couple of ways that you can see a psychologist other than through a GP referral. But let's talk about the GP referral first. GPs can refer you under what's called a mental health care plan, which currently provides 20 Medicare rebatable sessions per year. And that's a really, I think, a really generous Medicare rebatable option for care. You can also see a psychologist or a clinical psychologist in the community if you have private health insurance, in which case you don't need a GP referral. And thirdly, you can self-refer to a psychologist, and in that case you will be, without health insurance, you'd be liable for the whole out-of-pocket expense. So you might wonder how you would find the right psychologist for you. Well, your GP may be able to recommend someone, or you can search online, and I've given you two websites there. One is the Australian Psychological Society and the other is the Australian Clinical Psychological Association. And both of these organisations have find a psychologist functions. So you would type into those functions the area in which you live and the type of issue for which you need help. Now, of course, with telehealth as an increasingly used option, it matters less where you live. But still, for some people, it is quite preferable to see a clinician in person. And then finally, your GP, as I said, can refer you to a psychiatrist if necessary. And psychiatrists provide talking therapy as well. But unlike psychologists, they can prescribe medication for management of illnesses like depression and anxiety, and also for serious mental illnesses. If we go down the community-based support route, I've listed a number of organisations here that are evidence-based and where the information has been checked and would be reliable. So some are breast cancer specific, like Counterpart, which was formerly BRECAM, and provides support for breast and gynecologic cancer, and of course BCNA. But the others are generic and provide support for all sorts of cancers. Beyond Blue, of course, is an excellent resource. for managing mental health difficulties. So I would encourage you to go online and investigate the quite extensive information and supports that are available, with the knowledge that this information is factually correct. So when I think about mental health and psychological adaptation to breast cancer, although the same could be said of any cancer, I think about moving from a situation in which it might feel like the cancer has taken over your whole life, your identity, your every waking thought and moment, to a situation, a shift where you're able to make some space within yourself for this diagnosis, for its treatment, for the prognosis. And doing this means that it no longer defines you or controls you. So sometimes women can feel so consumed by their breast cancer that they forget, or they feel that they've forgotten that they are much more than their diagnosis. And so I think in a lot of ways of adapting to breast cancer, regardless of what your diagnosis or your prognosis is, as a process of reclaiming yourself. And I realise that this seems easy to say and it's not easy to do, but my belief is that it's certainly possible. So this is my final slide, and I'd like to leave you with some thoughts on promoting and maintaining your mental health. And these points again are applicable to everyone. So first of all, speak up. Speak up not only about your physical needs, but also about your mental health needs. Don't say that you are fine or that you are okay when you're actually not. Even the best oncologist, the best nurse, the best psychologist is not a very good mind reader. Second, accept help if it's offered. I don't just mean from your treatment team, I mean also from people in your community, from your friends, from your family. Next time someone says, is there anything I can do for you? Can I help you in some way? Say yes, actually there is, and give them something practical that they can help you with. My third tip is to stay informed, because knowledge is power, but to be judicious about the source of your information. Social media is rarely the most reliable source of information. Your treating team are usually the most reliable source of information about your circumstances. My next point is around exercise. Now, you don't need to train for a marathon, but do get moving. This is very well established now, and the beneficial effects for your mental and physical health are very well documented. So moving more onto the sort of touchy-feely psychology type things, I would invite you to practice self-compassion. So self-compassion means being warm and understanding towards yourself when you are suffering, when you're failing, or when you feel inadequate, rather than ignoring your pain or beating yourself up about this perceived failure. Self-compassion means that you recognize that suffering is part of a shared human experience. It's something that we all go through, rather than something that happens to you or to me alone. And self-compassion also involves a mindful awareness of thoughts and feelings, so that we can observe those thoughts and feelings as they are, without denying them or suppressing them. It is not possible for you to ignore your pain and to feel compassion for yourself at the same time. And self-compassion is very much a skill that can be taught. Now, a part of good mental health, I should say, that goes together with self-compassion is acceptance. And by acceptance, I don't mean resignation or self-defeat, because that implies that something is being done to you. Instead, I mean acceptance as a choice that you make to accept certain painful feelings and thoughts without trying to fight them or struggle against them. And acceptance is very, very powerful when you are committed to living your life, no matter how long or short that might be, in accordance with your values. So I encourage you to identify that which you value in your life. I also invite you to have goals, but these goals need to be realistic and achievable, and you must pace yourself or let somebody help you with pacing. If you set goals that are not realistic and not achievable, you set yourself up for failure, and that's not helpful. I invite you to focus on those things that you can control and to let go of the rest. And this is easier said than done, I know that, but you can work towards this goal with a psychologist or another peer, or indeed using self-help resources. And you can identify what can be changed and what cannot, and then practice acceptance. Finally, I invite you to practice gratitude. There's quite a large evidence base emerging now about the benefits of gratitude for mental health. And you may be feeling that you don't have a great deal for which to be grateful, and certainly not many people are grateful for a diagnosis of cancer. But perhaps also think about those aspects of your life for which you are grateful. And that could be a loving partner, it could be healthy children, it could be living in a first world country with access to first world medicine and treatments. And then consider what it might be like to not have these things in your life. And that's what gratitude is about. So I think that's me, folks. Thank you very much for your time today. I think I've gone a little bit faster than I had intended to, but I'm very happy to take questions, and I guess I wish you all the very best in somewhat trying times. Thank you.
Thank you, Lesley. And we do have some questions coming through already, but before we do get underway with questions, I did just want to remind people that it is important that the questions we're sending through are general in nature and are not specific, because obviously if people do have specific challenges, then they need to seek help with that. So thanks, Leslie, that was great. One question for me that often comes up is much more at a systems level, and that is, how do we really encourage health professionals at every element of a cancer diagnosis to think about their role in helping people to be referred into programs that exist? Because it seems to me that it often gets left to the nurse to have those conversations.
Yeah, I think one of the stumbling blocks is that there's often no one to refer to that immediately comes to mind. And, you know, there's a bit of evidence that suggests that oncologists, nurses, essentially anyone who's not a mental health worker, can be reluctant to raise the issue of mental health because they don't know what to do with it once it's out of the box. So hence talks like this today, to kind of educate the community that even if your service doesn't have a dedicated social worker or nurse counsellor or psychologist or psychiatrist, there are GPs who are very highly skilled, and there are good community-based networks that can support the majority of people, because as you go up that pyramid, it's only a small number who actually need specialised services. So there's a piece to be done around more educating, but then I think there's also a piece of work to be done around conveying the value, the shared value that mental health is everybody's business. It's not a discrete, separate part of health. It's it's a part of health that can't be separated off from physical health.
And I'm hoping one of the silver linings, obviously, COVID has brought to the surface many mental health issues for many Australians, whether they're working in the healthcare system or just in the community. And let's hope that we're kind of, by talking about it more, you take away that taboo around some of the points you made in your slide about that you're not strong if you're the one asking for help. So let's hope we're kind of dealing with some of that through the COVID experience. So there has been sorry,
on that topic of not being strong and seeking help as a sign of weakness, I often talk about with the women who come and see me how a parent manages their cancer diagnosis is a really important opportunity to model to your children what is an adaptive, healthy way to cope with a significant stress. So if you can model to your kids and to those who look to you for advice, that you're able to make an insightful choice about how you manage your problems, rather than, say, perhaps using drugs or drinking or something like that, then you've actually done your children a great service, and that works in with their own resilience as they face challenges through their lives.
Yeah. So we've got a question that's come through from Lily, and it's interesting because when we talk to our consumers, and in fact their feedback in preparation for today was how there's different needs at different parts of the diagnosis, and that moment of time when you're first diagnosed, when there's a gap between seeing your having your first appointment is an enormous kind of risk area. But then Lily asked, at the time of returning to work, what steps do managers need to put forward, such as a return to work plan, like an injured person? So I don't know if you've got a...
Yeah, look, as I said in one of my slides, I think you do have to pace yourself. I think there tends to be this sort of feeling like, I've completed my treatment now, it's done, I'm well, I can bounce back. But in fact, we are not a jack in the box. No one is a jack in the box, and you do have to pace yourself. And so I would often say, think about what you would advise your best friend or your sister or your mother when they're returning to work. You would say, take it easy, do it in a graded way, have a discussion with your boss about what you think you can do and what the contingency plan would be if it turns out that you can't do that. And if in doubt, have a discussion with your nurse or with your oncologist about their experience. So of course, this is your first rodeo, but not their first rodeo. So they're likely to have a lot of experience around return to work based on different kinds of occupations.
Yeah, and Lily, I would say BCNA, through the support of Suzanne Group, developed a work and breast cancer hub, and we've actually done a number of programs where we talk to the employers and the employees about a return to work plan in different scenarios, because big businesses have a much better infrastructure of helping people to return to work in lots of cases, rather than single-owned, organisations. So the Work and Breast Cancer Hub can be found through our My Journey online tool. There is a question here from Vicky. With the increase of mental health care plan visits, do you think there's still out of reach for those who can't afford the out-of-pocket costs seeking psychological help?
Good question, Vicky. I wish I could say that with the increase of visits, this means that the cost will go down. I don't think that will be the case. I think, in fact, there is a risk of the opposite. So we're in a bit of a pickle in terms of mental health and psychology services within public hospitals. There aren't roles, there aren't jobs for publicly funded psychologists, and so graduating psychologists gravitate to private practice because there aren't hospital jobs. And so to go to private practice, you set your own rates, just as doctors do. It becomes a business it has to be financially viable. So I wish I could say that this would increase affordability. I don't know that that's going to be the case though. And that's probably an unpopular answer, but I think that's the truth.
Yeah, and I think that's why you pointed to Beyond Blue and, Canteen, where they're giving support for families who've, not only if your child has had cancer, but actually if you as the parent have children, those children can access support from Canteen, as can the family members, and they provide psychological support as well. And I think that is about tapping into the programs and services that are already available. And for me, it's about that referral once again, because quite often people don't find out about these kind of programs and services or how to navigate the system until it's too late. So we've all got a role to play in making sure we get that information to people. And as you said, that information is power. A question's coming from Shirong. Thank you, she first of all says. And then she said, in LMICSs, now this is something we're all very good at in health area of talking in acronyms, but with limited resources to women with breast cancer, how should they maintain their mental health in your opinion? Or are there any so far related evidence-based interventions?
So I take it LMIS is low to middle income countries. Shirong, I take it.
Yeah, that's.
Yeah, look, I think some of the principles that I talked about in the slide of maintaining and promoting mental health would be relevant here. So there is a lot of self-help. If you have internet access in a poorer country to some of the resources that are around in the more well-off countries, I think that you can make substantial inroads. So one of the ways that you could think about doing that is for the health professionals in these lower income countries to collate the information that they find on the internet and pull that together in a way that makes sense for their local population. So without having to reinvent the wheel, just repurposing that information to make it locally relevant. I don't know if that's helpful to you, but there's no short answer to lack of resources.
Exactly, but I think we've certainly here in Australia had one positive step forward with that increase in the mental health plan, but we do need to make sure that here we are capturing the most vulnerable. So to that point around the access, how do we stop this notion that we've got to put on this brave face when we're talking with our clinician? What advice would you be giving to clinicians about how to really see through those brave faces, or to the consumer about going in and pretending that everything's okay when it's not? How do we push through this?
So when it comes to the consumer, what I would say is, when you present to your oncologist or to your nurse with your brave face, is that helpful to you ultimately? What do you achieve when you do that? And consider the alternative of showing your vulnerability, of showing that you do need help, and open your mind to what you could achieve by letting down that guard. So, I think we all rely on ways of doing things because they've been helpful to us in the past. But it reaches the point where that way of being is no longer helpful. And if you are struggling, but don't ask for help because you won't show that you need help, then that way of being is not helpful anymore. So that's what I would say to a consumer. Ask yourself if this is actually helpful for me. For our oncologists and our nurses, but I guess my experience of breast care nurses is that they are wonderful, marvelous creatures who absorb an enormous amount of psychological distress from the patient group. And certainly in our service here in the VCCC with the Royal Melbourne, Royal Women's and Peter Mac, we are very lucky We have, a number of breast care nurses. We do have specialist services, and we do work together in a strong team. So, my view is somewhat coloured by this exceptional experience of care that I believe our patients get. For standalone doctors, nurses, who are out there in more regional areas without support, I guess I encourage you to make yourself aware of that which you don't know. So to make yourself aware of how common mental illness is, how common distress is, even if it's not formal mental illness, and to kind of put together a little toolkit of referral options for patients in your area so that you have something on hand. And that can be really useful rather than sort of having to scrabble around each time looking for something. So you might want to consider contacting a number of psychologists that you find on those websites and asking them if they would be prepared to see patients that you would refer to them, and what their rates are and what their experience is with breast cancer, for example.
And certainly telehealth has helped with that accessibility for particularly our regional patients who, of course, BCNA worries about them the most, really.
Yeah.
There's a question here from Anu. What would be some useful techniques to work with building acceptance to the loss of breasts? What a great question.
Oh, what did I tell you, Kirsten, about asking me questions that require lengthy answers? What are some useful techniques? Don't know that I can really do this question any justice in this setting. And so I think rather than give a sort of half information, I think I'm going to have to decline an answer on that one, because I don't have any really quick kind of couple of sentence answers to go with that one. I'm sorry.
That's okay. So Anu, we at BCNA, we know how much of a challenge this is, and do have some great webcasts on body image that specifically talks to this, because there's obviously the women who are determined to be rebuilt and reconstruction, and those who make other choices to not have reconstruction. So there's lots of different elements to this, Lesley. So Anu, you can definitely go to our My Journey online tool to have a look at some of the work we've done and information we have around the body image. So we've got another one. Actually, I'm going to broaden this more slightly. The opinion about withholding news of a diagnosis from elderly, frail parent when the parent is the carer. But I think, well, let's be a bit broader about withholding a cancer diagnosis to others, like kids as well.
Yeah. So my view is that the worst way to hear about someone's diagnosis is to overhear it. And I am not in favour of concealing information, particularly from children. I think that we do need to be developmentally appropriate in the detail around the information that we share, but everybody deserves to know something. And the thing about children, and I imagine this is true of an older, frail person as well, who has their cognitive capacities intact, is that you do know something is up when people are whispering or crying or behaving in a way that's different to usual. And I guess the problem is that if you don't provide them with some reasonable explanation for that, they will fill in the gaps for themselves. And those gaps, the way those gaps are filled in, can actually be very harmful. The other thing about this, particularly with children, is that it is about trust. And, you know, you get lots of do-overs with your children, of course, but it's very hard to rebuild trust if you break that trust. And so, in as far as possible, I would encourage adults to share their diagnosis with their families.
And with elderly parents, same view?
Similarly, I guess. I mean, it's one would have to, I suppose, take things on a case-by-case basis, but I think we run the risk of infantilizing people or patronizing them. And I, you know, for me, there would have to be a compelling reason to do that. So I guess there's no blanket rule with all of these things, but my policy is towards transparency in an appropriate way. There's little to be gained by overwhelming someone with detail. But as I say, in the absence of providing information, those gaps get filled in, usually inaccurately.
Yeah. And it is about reaching out, as our consumer representatives tell us, that there is no one size fits all, and it is about looking at everyone's individual situation and doing what's best, but going in with an open eyes to doing what's best with the support that you need as well. There is a question from Liz Foster. What have you found from patients' experiences with dealing with health professionals in masks through COVID? And has this made it more difficult to read or hear emotions and distress?
Look, I don't know so much about patients, but I have struggled. I've really struggled in as a health professional to get an accurate read on affect, and it makes it that much harder. So I think where you're in a situation with a new relationship, so a new appointment between the patient and the clinician, and you don't have a baseline, you don't have a context, I think that is very tricky. Where the relationship is more long-standing and you at least do have a baseline, I think you can negotiate it. But certainly it's very difficult. So one of the workarounds to that has been video health, which is available in some settings. But again, something is lost, isn't it? When you have your consultations over video and you don't have a real sense of what it's like to be in the room with that person. So yes, I'm absolutely with you, Liz, that if what you're saying is that it has made life a little bit more difficult, I think in lots of ways it has made things a bit more difficult. Yeah. Kirsten, can I just go back to the question about acceptance?
Yes.
So in thinking about this, it was Anu, I think, who asked me. Was it Anu who asked the question?
Yes.
Acceptance is it's a process, and there are lots of good resources online, at free resources as well, to learn about acceptance. If you went and had a look at acceptance and commitment therapy, and Googled that, for example, you would find some useful exercises. One of the exercises, and I think to call it exercises is to probably diminish it, but is to learn mindfulness. So mindfulness is a word that's thrown around a great deal these days, and it has lost much of its core meaning. But when I talk about mindfulness, I talk about moment by moment awareness without judging the way that you are thinking or feeling, without judging your sensations. When you learn mindfulness, you become less reactive to the things that are happening or the things that you're feeling in your body. And so this is kind of a long way around of saying there's some great mindfulness apps that you can download. I think Headspace has one of those that will talk you through exercises like a body scan, where you focus in a sort of methodical, systematic way on different parts of your body, and notice the sensations and the feelings and kind of habituate to those feelings without trying to make them go away. And that's really a terrific first step in the process of acceptance. I'm obviously oversimplifying quite a bit, but I feel bad for you to go home without having had any answer from me at all. And what we find with women who have had breast cancer or had mastectomy, reconstruction or no reconstruction, is that when they do these body scans over the breast area, initially it is very difficult. And they're not able to linger on that area for very long. But as their mindfulness capacities increase over time, they are able to sit with those feelings and sensations and become less reactive. And all of that is part of a process of acceptance.
Yeah, no, that's fantastic, Lesley. And I think Smiling Minds is also another great app.
Smiling Minds, yeah.
Yeah, that helps people with that. I guess I wanted to end on a question around access right now. I mean, we're seeing this enormous increase in demand for people to go and seek mental health services. What do we do? What do we need to look at doing to make sure that we have the number of services we need in place?
We need investment in mental health in the public sector. That's what we need. My personal view, and it is a personal view, it's not the Royal Women's Hospital view, it's that we have all this federal investment in the Better Access program and now increasing that to 20 sessions. I think there needs to, and government hospitals in Victoria are funded locally, so the two systems don't really speak to each other that well. What we need is significant investment in hospital systems and in cancer treatment systems where distress is really truly recognised and translated into something meaningful. So it's distress is the sixth vital sign in cancer, but translating that into a meaningful service. And so that's what would be one aspect, would be increasing mental health funding. But the other would be increasing GP capacity. So our GPs are flat out and they can't do everything. So there's a real need to build infrastructure around them and build their capacity to manage the growing influx of mental health patients with mental health problems, shall we say.
Well, you can be sure we will be advocating for that, Lesley, because we know how important it is for people to get care early, to make sure that, for those who have early breast cancer, that they can get back into life and back to contributing to the community, but also for those metastatic patients, that they have the right support for them to have the very best quality of life that we should afford here in Australia. I did just want to make a quick note before we finish on the COVID question. So BCNA completed, through the leadership of Vicky Durston, our Director of Policy and Advocacy, and Lisa Morstan in our policy team, did a member survey on the impacts of COVID. There's two things that really stood out to me in that report. One is people's inability to access allied health, which obviously supportive care really fits in, and psychological care fits into that allied health. But the other is that we saw a dramatic increase in people's anxiety and stress over COVID, which I don't think has yet come straight back down. So we really, as health professionals, need to be very cognizant of that and really make sure that at every appointment we're checking in on people and how they're feeling and referring them to appropriate services. But the other was around the use of telehealth by health professionals. And there are still far too many health professionals using telephone only, when the whole notion of telehealth is about setting up a video call. And we really need health professionals to make sure that if they're giving any news at all, that they put appropriate supportive care features around that woman or man that they're going to be delivering that information to. And we know that there's still many challenges around support and carers being able to come to appointments in the hospital settings. And I think we really need to make sure that if we're truly being patient-centred, that we're thinking about what the experience is going to be like for the patient of being told information over the phone without that facial connection. And so I really think that I want to make sure that we continue with telehealth, but we do it in a much more patient-centered and much more awareness about what it's like for the person on the other side. So I'm pretty proud of the role BCNA is playing into making sure that we can shape some of those policies going forward. So we are 1 minute over time, Lesley, and I always get in trouble if I'm not on time. Thank you so much. And your final dot point was about being grateful and having gratitude. And you will certainly make my list tonight that you presented today and really brought to the forefront the very important part of our mental health, not just for those people who have been diagnosed, but for all of us. And I think particularly at this time, health professionals also need to be looking after their own mental health. So thank you for that very enlightening presentation. It does bring us to a close. I would encourage everyone to check out all the other events that are happening by the VCCC and thank the VCCC for continuing to provide great educational supports during these Monday lunches. And be safe, everyone, and write down 3 things you're grateful for tonight. Thanks, Lesley.
Thank you, Kirsten.